Okay, welcome to the ESMO Signalling Pathway Roundtable discussion. And we're talking about her pathway signalling, how it's working in the three important cancers, breast cancer, lung cancer, and colorectal cancer. And we have three international experts to discuss this. So I'm going to turn first to Luca Gianni to talk to us about targeting the HER pathway in breast cancer.
Well, breast cancer is the solid tumor where we're very lucky to start with, because we had a dissection of the molecular characteristics of the tumor very early, and it became soon apparent that having an HER2 overexpression and amplification was associated with specific characteristics, and there was the possibility to hit the HER2 and have therapeutic effects. And that has brought along a very successful story of very effective therapies for targeted therapies for HER2 positive breast cancer that has basically changed the fate of the women affected by the tumor. So I think that in terms of targeted drugs and targeted therapy and precision therapy in a way for solid tumors in breast cancer, with the HER2 overexpression was an outstanding example and continue to be.
And what difference has that made to cure for women with HER2 positive breast cancer?
Well, you know, there has been a simulation that shows that the application of HER2-directed therapies early on in the adjuvant phase to women carrying an HER2 positive breast cancer cuts death due to breast cancer by more than 15%. And this is an incredible achievement, because a single therapeutic intervention is capable of changing dramatically the course of a disease. Until 2005, having HER2 positive breast cancer was associated with a worse prognosis than having a cancer without HER2 overexpression. Nowadays, paradoxically, doctors feel almost reassured when they have a case with HER2 overexpression, because they have such fantastic armamentarium of drugs to hit the tumor and eventually eradicate it.
So there's been a great change in breast cancer. Let's think about lung cancer. Jean-Yves Douillard.
The situation is a bit different in lung cancer, but to my understanding, non-small cell lung cancer is the best example of personalized medicine application. In addition to a new pathological classification, essentially for adenocarcinoma, we now have a molecular classification, and we have been able to identify multiple potential targets in terms of mutation or overexpression. Of course, the EGFR mutation is more advanced than other. It's roughly, let's say, 15%. Of the patient with stage 4 non-small cell lung cancer. But in addition to that, we know that there are ALK-ML4 translocation, for which we have a drug. We also know that PI3K might be an important target, and drugs are presently under evaluation. So the whole concept of small cell, non-small cell has to be dissected into multiple diseases according to a molecular profile. The situation for lung cancer, as opposed to breast or colorectal cancer, is the access to tissue. We don't have that much of tissue. The majority of patients diagnosed with non-small cell lung cancer are metastatic disease, so we have small biopsy, and this remains an issue on which we have to work and find some alternative techniques to identify those mutations in order to offer the patient the best treatment presently available. We have been making progress essentially by better patient selection based on molecular profile. That's why we have certain groups of patients with longer survival, but in terms of cure rate, We are not as successful as our colleague in breast cancer. We have not found anything in the adjuvant situation so far.
We'll come back to discuss that in a moment. Dirk, would you like to give us your opener on colorectal cancer?
Well, just add to the last sentence of Jean-Yves, we're even less successful in colorectal cancer, unfortunately, for targeting EGF receptor family in colorectal cancer. We have learned in colorectal cancer that the expression per se does not mean that there might be activity. That's the lesson we learned in refractory colorectal cancer for targeting the EGFR1 receptor, because the efficacy of these drugs, of the antibodies being given, is entirely independent from expression or not. And even amplification does not seem to play a major role in this. In colorectal cancer, we have learned that downstream signaling is much more important, or even as important, for the efficacy of those drugs, because we have learned that the existence of a KRAS mutation, meaning the permanent activation of the downstream pathway, really rules out the expression or the amplification of the receptor. So therefore, the focus is rather on the downstream pathway than on the receptor expression. And we have also learned that even this single biomarker we use in colorectal cancer today is not very predictive in terms of efficacy. It's a negative predictive marker, so meaning we know by patients bearing these KRAS mutations which should not be treated, and on the other way, we do not necessarily know whether the others all have to be treated, because the benefit is not as large as in breast cancer or in lung cancer for those who were patient group where we exclude the mutation. So therefore, I think there's much of development, and the picture is less clear in colorectal cancer compared to the other cancer types.
Okay, so the question arises, why has the approach of targeting this pathway in colorectal cancer and lung cancer not fulfilled the promise that we've seen of targeting HER2 in breast cancer? Why do we think we are failing in these two? We've raised a bit of the question there. Would you like to try and give a precise answer to that?
Well, in lung cancer, as soon as we have identified a biomarker with a predictive effect on efficacy, we have nice results up front.
Nice results in terms of improved survival? Or
improved survival by patient selection, longer progression-free survival, better response rate, better quality of life, if you think of for example, the EGFR TKI, or crizotinib in our translocated patients. But we won't cure any of these patients again. They will all relapse. So resistance will develop. And it is important to identify what is the reason for resistance. There are multiple possibilities. And as I said before, it would be nice to rebiopsy those patients to identify the resistance mechanism and try to use the appropriate drug.
So we have different types of molecular target here: gene amplification, mutation, or what is the target in colorectal cancer for the EGFR? Is that type of the molecular target actually important in determining how successful we are?
I think that more important is what the alteration, the molecular alteration role, what is the role of the molecular alteration. And in the case of breast cancer with HER2 amplification, there is a driving force associated with that and with the expression of the HER2. But within the tumors that carry and express HER2, there are those who are not, that are not amplified, who really do not care about exposure to an HER2-directed drug. So the point is, what is the alteration associated with HER2 amplification that makes HER2 so relevant, and to the point that hitting HER2 gets to a therapeutic benefit. And that is the element that I think is a common theme also in other diseases for other alterations.
So do we know the answer to that question?
While we try to understand and dissect the answer, is not a problem of drugs. Many of the drugs that we use have an affinity for the target that is way beyond what is needed to completely block the target or eliminate the target from the cells. So we know that is not insufficient potency or inadequate drug exposure that plays a role. It must be something associated with the drivers of the tumors that we have to dissect.
I think we can clearly see this in the colorectal cancer story, because there we learn even if the tumor is expressing EGFR1 and even the tumor has no KRAS mutation, we can see that the drug works in delay of progression, but after several weeks, meaning in refractory patients like 6 weeks, more than 50% of those being treated are progressing at the next stage. So we're delaying the tumor progression for about 6 to 8 weeks, which may be important in the refractory situation, but this clearly tells us the story that the tumor is developing mechanisms against this pathway, and therefore this pathway, this driving force, is not relevant for those patients. Very recently, we have learned that, for example, the KRAS mutations may occur in some of those patients being initially wild type, so being candidate for this. But that's only, again, a minority of those who become refractory. So therefore, this indicates more than 50% of the patients develop other mechanisms, and the minority only of them develop this one single mechanism we have identified to be responsible for resistance against. So this shows the polyvalence of the approach of the tumor.
Okay, so Bert Vogelstein said in a paper last year, resistance is a fait accompli. The time for resistance to occur is simply a function of how long it takes the resistant clone to repopulate the tumor. Do you agree? Is it always the case? And if not, why not?
Well, I would agree with that. I think, especially in lung cancer, the tumor are very heterogeneous. And when we have a small biopsy, we just look at what we have. And we know that along the EGFR pathway, for example, there may be multiple mutations. And this does not mean that 100% of the cells are mutated. And those will be responsible for failure and later progression. We can act on the cells harboring the mutation, but the other clones within the tumor will progress at their own path. And this is, to me, the most probable reason for failure.
So in colorectal and lung cancer, we've talked about stage 4 disease always, so far, with the use of these agents, or almost exclusively, and we clearly see the rapid emergence of resistance. In breast cancer, you've used Herceptin successfully in adjuvant therapy, and that's really where the cures have come. So is it a nature of HER2 and breast cancer, or is it a fact of using it earlier in the disease course, perhaps?
Well, it's both, I believe. I mean, I have no doubt that emergence of resistance is a matter of time in any tumor that we know of. And that it is now obvious and clear, including in breast cancer, that heterogeneity is a classical characteristics and feature of any tumor that arise in the body. So the problem is to devise strategies that exploit different mechanisms to hit the tumor, and that is, for instance, in the case of HER2 overexpressing tumors, is the reason why it's not so easy to give up on chemotherapy, because heterogeneity means also that you have overexpression and amplification of the HER2 in a fraction of the cells. And if you are too selective with your targeted drugs, you basically lose all the other cells that do not carry the target. So you need to aggress and attack the tumor on several levels and on several aspects. The additional point that you made is also very important. And in breast cancer, we applied very soon targeted drugs against HER2 in the adjuvant and neoadjuvant setting. And this puts the drugs in a context where you also include the surgery, radiation therapy, and other drugs, and so that overall you have a spawn attack to the tumor, and you may have a chance of eradicating it.
So let me put that point to our two experts here. What about using targeted therapies in earlier stage disease, in lung and colorectal cancer? Where have we got to on that?
Well, in lung cancer, with the use of EGFR TKI, some studies have been performed and have been terminated early because of failure. So obviously, it's not working in the adjuvant setting. We don't have the result yet of other agents, namely bevacizumab or cetuximab in the adjuvant setting for non-small cell lung cancer, but we may face what we have seen in colorectal cancer as well, I'm afraid.
As already told, I think colorectal cancer, we have a clear story of failure for the monoclonal antibodies targeting the EGFR1 receptor. 2 trials being entirely negative. We can now speculate whether this is the interaction with the maybe not best chemotherapy as combination partner for this, but the standard approach of adding those drugs to standard chemotherapy clearly failed. And to be honest, we don't exactly know why. I think there had been much bet on this, that these trials would have been positive due to the anticipated mechanism of action, and I think many oncologists were surprised, but the picture is very clear. They were entirely negative without.
So that brings us on to the issue of what can we do about this. And many people will say combination therapy, combination with chemotherapy. We've heard in breast cancer. In colorectal, we've seen, and in lung, we've seen combination with conventional chemotherapy being a failure. So how do we move forward on this?
Well, I think that a very good way to move forward is that of attacking a valid target by using different drugs and with different mechanisms. And this is what we are doing for HER2 overexpressing tumors in breast cancer. We are using drugs. We have the good luck of having many drugs against HER2, and they attack the tumor through different mechanisms. And if you use, for instance, two monoclonal antibodies such as trastuzumab and pertuzumab, you have an incredible boost of activity and an additional benefit when you put the two drugs with chemotherapy. And this is something that is changing radically. I mean, we can double the rate of complete, pathologically assessed complete responses of HER2-positive tumors by adding a second HER2-targeted drugs. The same can be accomplished with lapatinib and trastuzumab, and now there are clear indications that a drug such as TDM1, which is a trastuzumab-carrying maytansine, a very toxic compound, with pertuzumab and docetaxel can achieve outstanding results as well. So that approach, at least in breast cancer, works because I think of the unique role of HER2 in that subset of tumors of breast cancer.
Okay, so and those early results are translating into improved long-term survival?
They are translating into improved progression-free survival and survival in metastatic breast cancer. And the expectation is that the ongoing adjuvant trials with those combinations will provide evidence of an additional benefit also in terms of survival of women with early breast cancer.
So the evidence points very strongly to the fact that HER2 amplification in breast cancer is a driver mutation for at least a proportion of these patients, and targeting it results in improved overall survival and cures. We don't have such clear-cut outcomes in lung or colorectal. Now, is this success perhaps related to the use of an antibody-based treatment approach vis-a-vis the tyrosine kinase inhibitor? Why are you not seeing successes in EGFR mutated non-small cell lung cancer?
That's probably true. As often as TKI have been combined with chemotherapy, they have not improved the outcome. We also know that these patients with an EGFR mutation are good responders to chemotherapy. Yeah. But it seems important to use both agents, not in combination, but sequentially. First line, second line. So it is our responsibility in academic research to design those trials that still should be done, to my understanding. The situation is a bit different with anti-EGFR antibody if I refer to the FLEX study, comparing vinorelbine cisplatin with or without cetuximab. This study, in a rather unselected patient population, except for the EGFR expression, even minimal, was significantly improving overall survival in stage 4, and additional studies looking at the intensity of expression of the receptor with a score in immunohistochemistry really showed a huge improvement in hazard ratio. Unfortunately, the drug was not registered, but the data exist and confirm that again, and maybe similarly to pertuzumab or trastuzumab, the monoclonal antibody added to chemotherapy is providing a further benefit, which we have never seen with TKI.
But we don't see that in colorectal cancer.
Correct. Again, for the combination with other multimodal treatments is really difficult because we have learned the story that likely would, I think we haven't been awaiting, is that the interaction of anti-EGFR treatment with chemotherapy plays an important role, as some of the regimen work synergistically and others don't for chemotherapy. So, for example, we would consider the combinations with oral fluoropyrimidines on the basis of 2 randomized phase 3 trial to be not the best combination partner, whereas infusional regimens of 5FU with oxaliplatin, irinotecan work nicely with these drugs. So therefore, the interaction with chemotherapy seems to play a role not only for increasing toxicity, but rather than also for the synergy of those. And this becomes even more complicated when we add radiotherapy. We have a handful of radiotherapy, chemo plus EGFR trials in rectal cancer, and can see that the effects are even detrimental, or likely even detrimental, in terms of pathological response. So therefore, I think we have too much more care on the interaction of chemotherapy, cell cycle, EGFR cell cycle, whatever we would see as mechanism of action.
So can I ask you, we are making progress in breast cancer, it's moving forward. We have made some progress in lung cancer, we are quite stuck in colorectal cancer. How do you see us as academic researchers and clinicians helping to move this field forward? What must we do next? Can I come round the table? Would you like to start us off?
So I think my personal interest would rather be to see which patient really hang on the inhibition of this mechanism of action, and this really drives the tumor for a long time. And I think the best way to identify this patient is to molecular characterize them upfront treatment, but to use this drug, for example, in a situation where you only have minimal residual disease, so meaning after combination with chemotherapy, and you have the remaining tumors in stage 4, and I think you have those remainers. I think there may be an even larger subgroup of patients which are highly dependent from those drugs, and therefore this would be a development. The other field would be to more precisely identify the molecular characteristics of these patients who have this high chance of being long time controlled by those drugs.
Thank you.
Yeah, I fully agree with Dirk, and this is what has been done actually in lung cancer with the concept of maintenance therapy, with a reduction of the tumor burden with induction chemotherapy, followed by maintenance with TKI, for example, and several trials have shown that there is a benefit on progression-free survival and on overall survival. The patients were not selected based on EGFR mutation, however.
And we are taking forward such a concept in colorectal cancer. So in breast cancer, your next step as an academic leading researcher?
Our next step is that of focusing as much as possible on very early stages of the disease and exploiting to the best the approved tool of neoadjuvant chemotherapy and neoadjuvant therapy of breast cancer. That is a unique opportunity. We know that we can do safely the administration of drugs before surgery for months without affecting the end results of the overall treatment in women with breast cancer. And with the application of drugs before surgery, we have a tremendous opportunity of investigating the characteristic of the tumor, not only on its own, but along the administration of the drugs. And that is basically revealing not only the a priori characteristic of the tumor that are associated with the highest probability of eradication, but also have the possibility of provide immediately the possibility of investigating what in the residual tumor after exposure to the drugs is associated with long-term failure and lack of success. And this approach is completely changing the field. We see years in advance on the neoadjuvant setting what will become apparent in the adjuvant setting after 5 or 6 or 7 years of observation. And I think that this is an outstanding opportunity which maybe can be tested and tried also in other disease types, although it's not so easy to transfer this concept from one disease to another disease.
Thank you. So perhaps we've learned this morning that one of the most important things is that we must have a target which is actually driving the cancer. HER2 does that in breast cancer. Perhaps EGFR does not do that in colorectal cancer, and in some patients the mutation does in non-small cell lung cancer. We've seen the importance of designing trials that can really identify which agents are effective in which patients, and the neoadjuvant window studies or the molecularly selected studies in maintenance following first-line therapy are good opportunities for that. We've had comments about the importance of the translational research with circulating analyses of the tumor DNA, and I think sequential biopsies are a vital part of this. So it's a challenge. Combination therapy has proven to be a mixed bag, often taking us backwards rather than taking us forwards. And there's a tremendous challenge to the application of these concepts to move forward, particularly cure for our patients. Thank you very much.
Thank you. Thank you.